Allisonn Agwu, who I'm so delighted to actually meet her almost in the flesh, but she has prepared a great talk for us. So she's going to go first for the first half an hour. And then Nina, who is here, and Grissel and Porchia are going to be a panel, as it were, with Jeff asking them different questions about their life experiences. Now, if you have questions, you can please put them in the chat. Michael will be monitoring that. Michael will be putting up an evaluation about a quarter of the way through, about 3/4 of the way through. And if you are available to stay longer, if we run out of town, I got my suitcases unpacking. That's my thing. If we run out of time, we can stay for another half an hour if people are available and if there's interest, because we don't want to cut anybody short because we know we have a lot of speakers. With that, it's 1 minute after. Let me introduce Allisonn, who is a professor of pediatric and adult infectious diseases at Johns Hopkins, director of pediatric adolescent HIV/AIDS program and accessing care early clinic, and I think well loved by people at Hopkins from what I've been told. So Allisonn, would you like to start with your presentation?
I sure can. I'm going to share my screen.
Excellent.
We're going to hope it's going to work, and we're going to do all of the things.
Yay!
All right. What do you see so far?
So far, your slide deck, and we can see your slides. You need to put it on the, it.
Yep.
Did it before.
I do.
And one more. Yeah.
Are we good?
Yes, we are.
Fantastic.
Looking good.
Thank you so much for having me today. Linda D, I've seen, I can't admit that we have not met in the flesh, but I feel like we have, but maybe it's just, it's coming through the screen. But it's obviously my honor to be here today. I'm going to present a lot of the information around lifetime survivors of HIV, challenges, opportunities. And really, I'd love to have this be a part of a dialogue, which it is. And so there are going to be times when I ask a question and I'm have people drop things in the chat, but I will stay as long as I can. I'm heading out to the airport to go to the collaboratory, the PAVE collaboratory meeting in Atlanta today. So had to catch a plane, so may not be able to stay the full half hour after. Well, let's get it. Briefly, disclosures. The objectives today are really to review epidemiology, and I had these as early acquired survivors, long-term survivors of early acquired HIV. Really want to talk a little bit about the life course, including outcomes and comorbidity, but emphasis really on challenges and opportunities for clinical care, but particularly for this forum, research, including cure research. I want you to be thinking about this lens as we're going through. What are the key questions for research? That when we're thinking about this, what are the key findings and take-home messages that I want you to take home with? So I'll circle back to the end. Why is this important? And I'll tell you right now, it's important because long-term survivors are an absolutely important population that we need to think about. And how is this related to cure? And why should we be excited about or not about this? And I think some of this should be part of the presentation, but really the dialogue that happens now. But I think we should start here with this slide, which I think is a celebratory slide, right? So we have gone in the 30 plus years since we first known infant to be born with HIV to where we are today. And what you see are major advances. On the left of the slide, meaning the first cases reported, the first cases in pediatrics reported, when we know by the time this report came out, half the young people, half the kids under the age of 13 had died by the time this report has come in. And then we saw major advances in AZT and prevention of perinatal transmission, to then ART, or full-on, highly active antiretroviral therapy. And the Time magazine here is David Ho. Here, then you move forward to 2013, the first to be cured of HIV, which we know later was not a cure, but still promise. And that's what's then led and sparked the pediatric collaboratory. I want to say, since that first Mississippi baby, there have been many kids that have been cured, but just as many more that are still living with HIV. And we'll talk about that in the next slides, and many of you are on today. And then a couple of things to highlight here. I am the community engagement director for the PAVE collaboratory, which is the first pediatric focused HIV collaboratory. And we'll talk a little bit about that. I'd be remiss, I'm talking very much from a US lens, And this is 2022 data showing the 15 to 49-year-olds living with HIV across the world, with an emphasis, again, talking from the US lens, but recognizing the dark red are where the large majority of individuals living with HIV is in Southern Africa. And when we think about this, we think about the kids that were living with HIV in 1990 and 2000, there are now the bulk or significant proportion of the adults living with HIV. So survivors are here in the US, but they're across the world. So what I'm talking about here today, again, US lens, but applies across the world. And here we are in the US, and we know the states where there are higher numbers of young people, now emerging adults and many older adults living with HIV who are long-term survivors, lifetime survivors. And I sit in Maryland. There are about 500 in Maryland. But I don't have to tell this group of those individuals who are lifetime survivors. The large majority are actually over the age of 13. Many of them in that 13 to 24 age range, about 50%. But I think the oldest person in my clinic is 38. And I know there's some others on the call who beat that, who are a little older than that, have a few gray hairs, but really want to make sure we are thinking about the whole life course, which is part of what I want to emphasize today. And this is just a little bit about the epidemic, where we know that it's more a Black and brown epidemic among this population. Breaking down, again, when we think about, oftentimes we're talking about youth and young people, really for young females, about half of those about 40% of young females in the 13 to 24 are perinatally acquired. So 40%. So when we're talking about adolescents, it's a lot of perinatally lifetime survivors who are here. For males, a smaller proportion, about 10%. And that's not because males are less likely to survive. That just means because the epidemic is much more a male epidemic among young individuals. More celebrations. You see yourself on this slide, and if you don't, you should be on this slide. Many adolescents, young adults who are lifetime survivors are thriving. We are doing great, all right? You are doing great. But oftentimes, this is where we focus, right? We focus on those young people are being less likely to be engaged in care, less likely to be virally suppressed. And we Debbie Downer here. And I think we should flip that. It's amazing that lifetime survivors are even suppressed, that 40% or 50% or what have are suppressed. But this is that when you look at that group, oftentimes they are having challenges. Instead of going to the slide and saying, here are all the challenges, I thought I would tell you about the all right. So this is the case of Miss X. She's a 30-year-old female survivor of HIV acquired at birth, lifetime survivor. Both her parents were HIV positive. Her mother passed away at 15, when she was 15, of complications of HIV and AIDS. Since the age of 11, her viral load has been up and down. The last time it was less than 50 was when she was 16. So this is now fast forward significant amount of time where she has just been struggling. And that includes through 2 pregnancies where she struggled with taking her antiretroviral therapy. I show you the regimens, not for you to read the regimens, but for you to know this is her 9th regimen that she is on. So lots of regimens from monotherapy to dual therapy. She is the story of HIV. Her current regimen included dolutegravir, bilpivirine, and darunavir cobicistat, which you may or may not know is a huge, right? And she was struggling with said regimen. Over the years, her regimens were changed to make things easier, but oftentimes because of virologic failure, and she had significant amount of resistance. And I show you that to show you lots of resistance, right? Her genotype tells the story of HIV, but she did have no integrase strand inhibitor mutation. I highlight her medical issues, cognitive limitation. She had, was born with HIV and definitely had some encephalopathy as a young age. So HIV had impacted her cognitive. She had significant amount of thrush. She had MAI, which is a opportunistic infection. She had diffuse rash in her skin called molluscum contagiosum, all signs that her immune system was struggling. Recurrent vaginal, she had an abnormal pap, she'd had pneumonias, and was hospitalized. This year was about 6 times that year that she had been hospitalized. CD4 count was 20 at its highest, and her viral load was given 10 million. I have the quote here, no matter what life throws at you, you keep smiling. Because regardless, every time you walk into the room, she smiled, she made it funny. She was like, this is what I got to deal with. And she oftentimes minimized her way of coping laughter. So she smiled through it all. But I don't have to tell you that you're more than your viral load, right? So when we talk to her, oh, it's greater than 10 million, but let's talk about why. Instead of showing you the viral load and all that, let's show you why. Her life. So cognitive developmental delay, significant pill burden. She had medication side effects to the wazoo. She had no social support. In fact, she had her 2 children and she was watching everybody else's children, right? Housing instability, because her staying with people was contingent upon whether or not she was going to do the things. It was transactional, even if it was her family. She had transportation difficulty, couldn't get to appointments. And if she got there, she had to get out to go take the kids to school, from school, what have you. Significant poverty, even though she got disability and got a check, well, that went to everybody else and she was paying for lots of things, right? And it's unemployed, on and off phone service. So you couldn't reach her, couldn't get her. And if you did, she missed things, what have you. No childcare. So again, what did she do? And then lots of stigma, both internal and external. I didn't do anything to be here. And, then stigma, well, she also has to use a different cup. And there's so many things happening even today. And then trauma upon trauma upon trauma. So this was December of 2021, and she was hospitalized for the 6th time that year, hypotensive, meaning blood pressure was low and in the ICU. And the plan was, let's continue your oral regimen, just keep doing it, get better, get good. But what now, right? So I think important, I show you that because we can pick out all the things that are persistent barriers to her being suppressed, persistent barriers to a good outcome, social determinants, disease determinants, all of it. So I think it's important when we talk about lifetime survivors, we need to think about the life course. I think for so long, with so many in an early age, we oftentimes thought we reached success when they were in the 10 to 19. Oh, they made it to their 2nd decade. But I've already told, and I hear and see there are many of you that are in your 4th decade, and there's no reason to say why you won't be in your 5th decade, 6th decade of life. So we need to think about all the things that are happening about life events at different decades, self-management, who's caring for, when do you know, disclosure, not disclosure, stigma, how does that change over the life course? How does the treatment change over the life course? How does adherence change? What are the variables that change with that, particularly as a life-term survivor? What are the comorbidities, known and unknown? And what does care delivery look like, from pediatric care all the way to adult care and hopefully to senior care? What does that look like? And what is the experience? And how does that interface with people's lives? And then what are the risk factors for what happens over the life course? I think it's important to throw this slide up because the bottom line is there are causes of death for all people who live in the US. And these are the top ones. And I'll show those for 25 and 35 to 54 and highlight those. Still unintentional injury. When you see the second cause for 25 to 34-year-olds, suicide. For 35 to 44, it's heart disease. And you start to see, again, homicide, neoplasms. These are things that all Americans are dying from. And that's the first thing I start up when talking to all my patients is, most people with HIV are having the same thing that everybody else in America is having. It's just a little added spice of your HIV. And so how do you interface that spice and how do you control it? It's important. You like that spice? I think important to say that we know now that HIV itself, whether it's the medications or the therapies, does have increased risk of inflammation, and that inflammation does lead to increased risk of non-AIDS defining illnesses. I don't think I have to tell this group that, but I want to highlight that. So what are we seeing? HIV, aging, medication, all of those coming together leading to increased probability of comorbidities, high blood pressure, diabetes, obesity, things that, again, that all Americans are dying from or having, and the impact of HIV added to that, layered on. Oftentimes, when we talk about these non-AIDS defining illnesses and the graying of the epidemic, it's oftentimes much older individuals that are shown, with an emphasis of those that are living 30 years that were diagnosed at 20. But what about those that are 30 years diagnosed at birth? And that's why we're having this conversation today. So what do we know? So HIV-1 persistence in survivors of early HIV. We know that there are factors that influence the development of reservoir or where the virus hides out. And that includes maternal ART, that includes unique environments, maybe some sex differences, right? We know that those reservoirs exist over time. And even in the setting of viral suppression, we do continue to have those reservoirs hiding out. And we also know that there are factors that lead to those coming back or reawakening in the setting of going off of therapy. So HIV persists, and even in the setting of being immunosuppressed, there's inflammation that happens. So how will long-term survivors be impacted? What do we know? What's the impact of cure? What's the impact of comorbidities? What do we know? How are the organs affected? How is the brain affected? We're finding over time with case reports and case series that there likely are going to be some effects. Let's talk a little bit about that. And that leads into hopefully where we'll talk about what's needed next. So how do we know what's happening? I think it's critically important to listen to the youth. This is a webinar I did a few years ago with some of the people I recognize on this call, talking about what the unique experiences of those women born with HIV at that time, but the lifetime survivors of all genders are important to highlight. Case reports and series, I say, see something, say something. I've done quite a bit of reporting on, seeing hepatocellular cancer in a person who has a lifetime survivor but didn't have hepatitis C, seeing a heart attack in a young person at 23, no history of heart disease, only just the HIV. Observational data being very important, and cohorts, the importance of looking in cohorts and bringing people together to say, well, what are we seeing? And then modeling studies and conversations like this. This is the full-on blockage of the coronary artery in a young man at 23, lifetime survivor. And this is a large cohort, the NA cohort, that we actually asked, what are you seeing among your young people? In reality, when we asked them this, they said, well, we don't have that many perinatals. We don't have that many. And then when we pushed them to look, turns out they had some. And they had to query the sites to figure out who they were, but they had some. So we don't want to take unknown, right? We want to say, well, what exactly is that risk? And let's try to qualify that, because if not, we won't know. So these are some of the long-term comorbidities that we're seeing. Some cardiovascular disease. This image here is showing that earlier on, people were dying with things related to AIDS-defining illnesses. As you move further out, it is not AIDS-defining illnesses. It's the cardiovascular disease, the malignancy. What is it? Medication side effects. How are we going to know? Metabolic abnormalities, CNS abnormalities, or central nervous system. And then again, long-standing inflammation and the consequence of lifelong ART, the consequence of lifelong HIV. These are just some graphics showing you that we know that those long-term comorbidities that we see are more likely to be seen when lower CD4 counts, it's data from Ann Nealon, or having no ART or being on non-suppressive ART. And we're also more likely to see those events as people age, right?
Mm-hmm.
And this is, so when you really quantify what those events are, number one, you see the bars out, it's STIs, or sexually transmitted infections. A lot of mental health and neurodevelopmental disorders. And then pregnancy, which is not a disorder, but seeing a lot of that, right? But just saying that this is what we're seeing in our young people when we look for it. I told you the NA Accord said they didn't have that many perinatal or lifetime survivors. If I slip up, just slap me, okay? Occasionally I'll slip up. So I'm going to go with the LTS. And Jason Hall is a postdoc that looked, and this is data that he presented the HIV and aging workshop showing actually significant amounts of type 2 diabetes in our lifetime survivors, hypercholesterol, high triglycerides or fat in your blood, chronic kidney disease up to 30% by age 30. And significant amounts of hypertension. So we're seeing it, and a lot of this higher than the general population. So before I go into what we can do in terms of research, I have your ear as a physician. I have to make sure I say there are things that you can do because there's layering on all the other things. So prevention, if you're smoking, stop. If you do things like this, what can we do to modify that? Make sure you screen. And the doctor says, well, you're too young to screen. Why don't you screen anyway, right? Pushing people to say, I might have some increased risk. Let's screen. Let's get that blood pressure lower. Let's talk about STI counseling. So all these things are important, right? And then taking your immunization. But how do we prove outcomes? You're here to talk from a research lens. I think it's important as we think about it, the multimodal strategies, right? So this is the 2023 pause chart showing all the remedies that we have. And this is only half the chart for treatment of HIV. We have stronger, longer, safer, simpler, right, regimens to even address when there's ART resistance. We have different delivery modes. We now have the injectables. I've gotten some of my young people on injectables, and it's life-changing for many of them. It's treatment and it's cure. And I have highlighted some of the strategies that are being studied for cure, because we can't forget this group when we talk about cure. But it's also improving engagement. It's behavioral and community interventions. It's optimizing care delivery models, where, when, how, what works for you, using tech, using personalized medicine. And then, yes, we need to, for all of this to inform this, it's research. So what research is needed? This is from the NIH and talking about just the different buckets that are needed for HIV research. Now, much of the time we've looked at HIV, we've spent our time in reducing the incidence, thinking about comorbidities, developing next generations, cross-cutting areas of thinking about all the above. And oftentimes, I'll be completely honest, we were so excited that our lifetime survivors had reached 10, 15, 20, that we didn't necessarily talk a lot about cure. And I was one of those researchers reporting on comorbidities and doing all of that, and was at the NIH talking about progress in pediatric HIV with one of my advocates, who'd been my patient for several years. And he was there, he participated in research studies, and we're talking about, oh, how great we've done, patting ourselves on the backs. And unscripted, his name is Maurice, he turned to the panel and said these words: because I was born positive, I've been a part of all kinds of research. I'm all about the advancements as long as the conversation pushes the pen forward for me. Because a lot of the time we leave out the 4-letter word cure, and we stick so much on treatment and adherence and being comfortable with how it is, which is all fine because we have to be accepting of where we are. But is there still a goal? Is constantly my question. And I'm not sure with a lot of the studies that I participated in, is it just to help us live comfortably, or is it to push it forward for us to eradicate it so there is no more? So that is just my years of experience in this and my expertise. He had never said that to me. He'd never brought that up. This is way before the PEDS collaboratory existed. And here he was challenging it. It's exciting to have a PEDS collaboratory. So I'd love to talk a little bit, and this is me brainstorming, but I'm here to talk with you about your brainstorming. Would love to hear your thoughts. Reasons why long-term survivors may or may not participate in research, whether it's treatment strategies or cure. I think first, it's lack of awareness, interest from the patient, from the doctor. It's never being asked, never even being considered to be part of these kinds of studies. We know there are biases in who gets approached to be in studies. We know that studies are more likely to have people that don't look like who's reflected in the overall epidemic. Oftentimes, there are strict requirements for the studies. I think we talked about my patient with all these different comorbidities, and oftentimes, your liver enzymes are this or there's that, you cannot participate. There's fear. There's the devil I know, is what I already know, and then there's this new drug. Will I have to stop my ART after years of telling me to take my ART? What do you mean I stop my ART? Will you give me placebo? What about side effects? Safety concerns. There's burden. Travel burden, frequent appointments. You go from potentially having medication once every 2 months to every 6 months to now having to come in multiple times every month, right? Every month or even more frequently. Childcare, missed work, cost. What are you reimbursing me for this time when I missed work, et cetera? And we cannot underemphasize the distrust, the mistrust, whether it's the medical system, the research system, what's happening, and this idea of being a guinea pig, and what have you done, and who has this been tested on, and why are you giving this to me now? Lack of assurance. I know my ART may be doing certain things. I may have an effective ART regimen. What about what you may do, and how will that impact me? Healthier, too healthy, I feel fine now, or not being sick enough, or being too sick. Many of those may be in. And many are just tired of research, tired of medicine, tired of research. I think there's, what about the opt-out consequences? The research studies are not patient-centric a lot of the time. There's a lack of follow-up, what's happening, what happened, lack of support to do it, like my young person that I talked about, confidentiality, stigma, disclosure, guilt, survivors. Well, I got an opportunity to do this, but no one else did. And then there are many others that I'd love to hear when we do our dialogue. This is data from Corinne Dubé, who I think is on the call. When I said others, that's where I want to hear your thoughts. And again, the participation, but she asked women and they told her the reasons why they would want to participate in cure research. I think we have to hear these voices to understand why or why not, and what would assist to do for research in general, and particularly around cure research. Highlighting a little bit about the paid community program. The goal is multi-level. It's to translate, take plain language so people understand where we are, what is happening with cure research. It's a network. So excited to be on here with the other collaborators to talk about what's happening, networking amongst each other and broader. And it's strengthening ethical development, identifying emerging social behavioral issues, having diverse representation. So literacy tools, foundational training before conferences to make sure we're on the same page, and increasing the presence of survivors early in the conversation and often. And again, so excited to be part of this today. One thing I want to elevate, because Karine is going to be working on this with us, I talked about the lifetime perspective and the life course perspective as we think about living and surviving with HIV. But what does that life course perspective mean for cure research? And again, the voices on the call who are in the second, third, fourth decade of life, there are things to be said about what's happening from a biological standpoint, those different phases, neurocognitive standpoint, mental health, sex differences that may impact how cure can happen or can't happen, but also stigma. What does it mean for stigma over those life course? What about informed consent? You've lived it. What does it need to include? We need to hear from you to do that. And what does autonomy mean at those different ages in your retrospective scope and how it can inform future? So where do we think we would love to go? Build stronger communications. Again, so excited to be here today with you all, the survivors, the daisies. I think we need to really participate in research literacy materials and developing that and making sure we're all on the same page, particularly with the remedies that may be coming out. And then we need to convene on cure advocacy issues, particularly as we think about, treatment interruption and different remedies that are coming. So what happened with Miss X? So what did we do? And I think you have to be intentional about what you do for all of this. So for cognitive delay and development, we said, you don't get to not come without help. Bring your help. Who's on your team? Engage a family. We use tech to do that. Virtual, in-person, what have you. For her pill burden, she actually is on a fully injectable regimen with cabalpivirine and lenacapavir. For medication side effects, switching to that, it resolved her diarrhea. Her no social support, we said you don't get a choice to not support. You got to support her and stop giving her your children to watch. Figured that out and gave some childcare vouchers and helped to do that. For housing instability, we supported and helped to do that. Transportation, we took it out of their hands to get her there and did rideshare for her appointment. She's been at every appointment. Poverty, we connected to services and engaged. For unemployment, we pause that for now. Let's work with all the other things. Work on your health and your improvement. Her on and off phone service, we gave her a phone and gave her minutes to use that phone. No childcare, again, provided vouchers. Stigma, counseling, trauma, counseling, engagement. You are enough, the messaging. And that's her decline in her viral load. And now she's 2 years and counting with a kind of suppressed viral load, and her CD4 is almost 400 from 20. So that's what it takes. So in conclusion, LTs are a unique population. You're aging and aged into adulthood. There are challenges, right? And there's potential comorbidities that occur across the life course, but we need to be aware of the potential impact of lifelong HIV. And we have to understand that it's key potentially to how we address things, but how cure may even happen, the different strategies we are looking at. But I think importantly, must specifically consider this population, all of you, when designing research questions, including cure research, bringing you in early, often, again, and not at the end, but at the beginning, the middle, the end, and again. So with that, I would like to stop and say thank you for the time. I'm looking forward to hearing what my LTs have to say. And it's okay to be a masterpiece and a work in progress at the same darn time. Thank you.
That was wonderful. Just wonderful. Do we have questions? Anything from the chat, Michael?
Yes, there's a lot, and I need a second to pull it together. But I think I would love to start off with some terms that we heard, and perhaps we would like to clarify what we were saying. We're saying lifetime survivors, and I heard the word in the chat about dandelions, and I didn't know if our panels wanted to talk specifically about these terms, where they came from, what we're saying when we say these things. I think that would be a great place to start to help people get their minds around that.
Hi, sure. I can start. First of all, thank you so much, Dr. Agwu, for that presentation. Yeah, so I think that's a really great place to start in terms of terminology, and I was really excited and happy to hear you use this term, Dr. Agwu. So lifetime survivors is new terminology that we came up with ourselves, right? So this is a term coming from our community, just in reflection of, you know, like, yes, we are also long-term survivors. And I think more than that, right, like we are a unique group of people, right, a population who are the only ones who can say have been living with this our entire lives, right? And from very early childhood. And it is an inclusive term of both like perinatal HIV, as well as including a lot of young children who acquired it through blood transfusion. And so we definitely include that population into our fold, acknowledging that we have a lot of similar experiences. So that's definitely a new term that we are asserting for ourselves, as well as the other one that we used to identify ourselves is that of dandelions. And so for anybody who is familiar with Mary Bowman's Dandelions poem, you know, we started to embrace that term to describe our experiences as well. So those are the two terms that hopefully, you know, the larger community will become more familiar and comfortable with in terms of using them. And I know, you know, there might be a little bit of confusion between lifetime and long-term survivorship and abbreviations and that, but, you know, we all learn new things. And so I feel confidence in our broader community that it'll be clarified. So just to start there.
We had the discussion about the acronym, because it's like LTS, and what should lifetime survivors be, you know, just LS maybe? I don't know. We're still working on it, but yeah.
It's a work in progress. That's great.
Difference, discrete difference that you can see LTS versus LS, you know?
Great. Thank you for that, because I think that's really wonderful. I love when people are self-defining and creating the definitions for themselves and the terms that they want to use. I think it goes all the way back to the Denver principles of how people there were saying we are people with AIDS. We're not a patient. We're not a victim. We are these things. And I think that's their power. And I'm so happy to hear you all helping us know how to refer to what you guys are talking about. Thank you so much for sharing that. Why don't we introduce
I think Jeff has a question next, Michael.
Yes, I was going to get to that, but I thought we should, since we have everyone's face, let's hear who's on with us before we get into more questions.
Yeah, you know what, ladies? We did not introduce you, Nina and Grissel and Porchia. So Grissel, we've heard from you. Tell us just a little bit about yourself, and then Nina and Porchia can do the same thing. I'm sorry. We're going back and forth with Jeff Taylor about the questions, so I apologize.
Yeah, sure. I know, and I also could have taken the time to introduce myself. So my name is Grissel Granados. I am based out of Los Angeles, California, and I have been living with HIV for coming up on 37 years next month.
Wow. And Nina?
My name is Nina Martinez, saying hello from Atlanta. I am a transfusion-acquired HIV survivor turned the country's first living kidney donor under the HIV Organ Policy Equity Act of 2013. And earlier this year, I donated a lymph node and serve on the CAB for RID HIV.
And Porchia?
And my name's Porchia Dees. I am born and raised in San Bernardino, California. And I have been living with HIV. I was born with HIV in '86. So I'm also going on 37 years strong in December as well.
That's great. Oh, it's great to see your smiling faces, all four of you there. Okay, Jeff, did you want to ask another question?
Yeah, and thank you, Dr. Agwu, for that great presentation. And I know we had talked a little bit the other week about the need for research, right? There was a lot of research that happened early on, and it's kind of been dropped. And sadly, it's become kind of a forgotten population. This happens a lot in HIV, kind of across the life spectrum. It used to happen with aging, and now we're trying to kind of correct that here with the lifetime survivors. So, more than just getting people back into cohorts and back into trials and allowing them to be included, right? A lot of times they're excluded for whatever reason. They don't quite fit into the boxes. And we encountered this with Research for Women as well. It's not just creating a place for them to join, but giving them a reason to join. So what kind of research would you like to see that is specific to you as lifetime survivors, so that we can really design research to address, your population and your specific issues as research questions?
So was that question for me or to or Dan?
To our panelists. I mean, if you want to weigh in as well, I'm sure you guys have opinions as well. But let's hear from our panelists at first. And if you have something you'd like to add, please do. So go ahead, Porchia. I see you.
Okay, I know there have been some studies that have already taken place for our population. I know Nina has talked to us about the COPE study, and I'm not sure if there were any before then, because I didn't even know about the COPE study until Nina told us about it. But I would want to see like a study that would kind of, and I'm not sure if the COPE study did that already, but would kind of like I guess a study the effects, like, and I know it studied some of it, but like of like the long-term, the medications and how they've affected our bodies long-term. I know, like many of us have, I'll speak for myself, but I feel like many of us have experienced that. But like, I have chronic kidney failure. I have, I know Miss Allisonn was talking about the cognitive issues. I call it HIV brain, but I don't know what's going on up there, but, kind of to study that. And just like the long-term effects of the inflammation from the virus, as well as like the medications of being on medications for our whole lives. I feel like the COPE study did that, but I'm not sure. I wasn't really privy of it until like really late. So
Nina, did you want to respond to that also and maybe catch everybody up who doesn't know the horror story of that COPE study and other studies that have ended prematurely like that?
It's not a horror story. It is a success story. COPE stands for Clinical Outcomes of People Who Acquired HIV in Early Life. It's a cohort of about 175 folks who were followed at the NIH Clinical Center. To be included in the cohort, you had to have acquired HIV within the first 10 years of life, and the study was designed to follow people for 10 years, assessing different clinical outcomes like renal, like bone, like liver, cardiac, brain. I don't know. They tested a lot because I was there a lot. So for 20 years, I have been a participant in various research studies at the NIH Clinical Center. And I started that because I was a college student at Georgetown and I was nearby. And then I learned that, when I moved to Georgia 2 years later in 2005, that they would travel me back. So while a lot of pediatric HIV survivors did travel to the clinical center to be a part of NCI's pediatric studies there, I was kind of a latecomer and just immediately started in the NIAID OPA clinic there at the clinical center. But the COPE study has had about 6 papers come out on various clinical outcomes. I can't summarize them for you, but I'm happy to share with whoever wants to see that list of papers. But they did specifically have a cohort for this. The study did end because Dr. Hadigan did take a different job within the clinical center. But I would love, if anybody knows Carl Diffenbach, there's no reason the study should keep ending, because we did provide good data and data that people need to learn about. To answer the question of, is there anything specific? I was late in coming into clinical research at age 19. I know a lot of people joined much earlier than I did. And so to ask them to participate in long-term follow-up studies, I mean, it would be great if Max or Wise would stop disqualifying against overly complex and treatment experienced patients, because like that's who we all are. Is we've taken, as Dr. Agwu demonstrated, several regimens. I know when I tried to enroll in WISE here in Atlanta, I was told that they didn't really want my participation because they wanted newly diagnosed people who had experience with the newer medications. So I think rather than designing something specific, I think we need to look at these exclusion criteria as people just copy and paste from different protocols and see, are these scientifically warranted and are they reflective of the real life experiences of the people that you want to study?
I think if I could just add, and I think that's all super, dead on what I think is your question, Jim. But I think the other piece that we need to, like I point out with the NA Accord, there are 2 here, 3 here, 5 here. They are existing, and we have to figure out how to make sure that we're following that. With NA Accord, when we asked, it was almost 500, but initial was 100, right? So it's being intentional, wanting to follow. And some people may not want to necessarily engage and come once a month or whatever, but their data is there, and they're happy to be able to see, like Jason showed, there are things happening, and then again, it piques our attention to them and look further.
I think the problem is, Nina, after we talked about that COPE study, it's been closed for like 10 years. Had we known that, we could have probably done something.
It just closed last year. Last year was.
Oh, I thought you told me 10 years.
No, the study lasts 10 years, but it just closed. Last year was the 10th year.
Well, maybe we can do something with Carl to do that. And I mean, I think that points to another issue of how we have left you out of the general community. I mean, and I don't think we've certainly not done that on purpose, but I mean, I think this is for cure research, for a lot of us, it's a new beginning of starting over and trying to do things the right way as far as inclusion of every community, and everybody that's on this call, that's put on this call, it really believes that firmly. So that's why we made sure to invite your community to tell us about your problems. But, maybe we can, let me see I'll talk to Carl and we'll see what we can come up with. I'm glad we clarified that, because I thought you said on the call it was 10 years ago. Right. Maybe we can resurrect it, because if somebody's got an intramural study going and somebody leaves, it doesn't mean the study should go away. I mean, that's insanity.
I mean, I think it's pretty funny how everyone's like, your life is so miraculous, but you don't want to study it anymore. Right. Right. I mean, you want to talk about HIV cure. I bet we have the key, but you're not interested because we're overly treatment experienced.
That happened with all the other cohort studies too, and we were able to save them, so let's see. I mean, it would have been easier if it hadn't closed at all, but let's see what we can do. Okay, well, talk to us about this general integration in the community. How can we do that better? I mean, we made sure to include you for this particular webinar series, but how do we make sure that happens all the time? And how can you help us with that?
I mean, I think it's one of the right pieces that Dr. Agwu kind of mentioned in her presentation in terms of including us in like all steps of research, right? So from concept development to protocol development to recruitment and, then the evaluation, analysis, dissemination, all of that, right? And so I think being able to have research that is both specific to our population, but also, like we don't have to reinvent the wheel, right? Just being intentional about recruiting from our population so that we are represented and that there is significant enough data to actually draw conclusions and analysis from. Because for the most part, even if we participate in research, oftentimes we are deemed to not be like enough people to be like significant data. And so when we talk about reasons for not wanting to participate in research, for me that's one of them, right? For me personally, I'm just kind of like, what's the point of me participating if at the end of the day you're basically going to throw away like my answers by putting them under other and insignificant data? So what really was the point and benefit of me participating? And I think having this specific recruitment from our population and being intentional about it, I think will one, give us more answers, will make us more interested in participating, and will also just make sure that we're being included and not made to be invisible by us being an afterthought. So I am grateful that we're having these conversations now, so that when it comes to protocol design and inclusion and exclusion criteria, we're specifically thinking about this population as well.
Yeah.
There's a follow-up question to that in the chat from Shakina Rose about, and so somebody mentioned how you're being excluded. Could you kind of expand on what those exclusion criteria are that are keeping you out of research, so we can, as advocates, know to get rid of those, just like we have for other populations?
I would throw the question back at you all in terms of what made you forget us. I think that's the thing, is that people thought most of us had died. I know 90% of people with hemophilia had died.
Mm-hmm.
So I don't fault people for thinking that, but I mean, it's pretty clear that we haven't. And I saw after the US conference on HIV and AIDS, a lot of long-term survivors say, I kind of forgot that there were people who had the unique experience of experiencing HIV-related stigma in childhood. That wasn't their experience, but there are people who did have that experience, and they're just as long-term survivors as those who are over 50.
Yeah, I'm just adding to what Nina said. I think we've gotten lost. Once we transitioned from pediatric care to adult care, we got lost in the whole entire HIV population at large. And so we were treated like adults, or, there weren't, I believe that there haven't been spaces since our childhood, like the camps and stuff that we've talked about, that have been specific and dedicated to us, because I think we just got lost in everything, And then I think, like Nina was saying too, as well, another one of the reasons why I feel like we're excluded is because of our because we've been on treatment for a long time. So that's one of the exclusion criteria that we're I guess we might have what is it? I can't even think of the word. I'm having a brain fart. But we might be resistant to some of the different medications, or we're treatment fatigue, and folks don't want to study those populations. So I feel like we get lost in that sense too, or excluded in that sense too. I heard Miss Allisonn say that you put some of your patients on Cabenuva, the injectable, and I know I have to fight. I mean, because they're saying I'm not a good candidate for it because of my, I guess, me being, they don't know what my my resistancy panel looks like or whatever. I don't know. So they're saying I'm not a good candidate for that. And that's in the same sense for a lot of the studies. I'm not a good candidate for the study. So
I mean, they're supposed to test you for that before you get on most of the studies.
It's hard to do that
certainly
if you have an undetectable viral
take
load.
the medicine. So that's not a truthful or proper answer.
They said because I'm undetectable, they would have to have my records from when I was younger to see what my resistancy panels would look like. I'm not sure. I don't know.
It could be different now than that's crazy.
But you have to have a detectable viral load in order to do the genotype resistance testing.
I understand.
Yeah.
I mean, I think to just answer your point about the exclusion criteria, I think it's understanding why we're doing what we're doing. I think it was Grissel that mentioned we just sort of take the same exclusion criteria and we populate the next study protocol. And so why is there a reason why we need this criteria to be what it is, and examine that for each protocol?
I did say that.
If we don't, then don't, right? Then don't have that as an exclusion criteria. I think sometimes there is that criteria that says the opinion of the investigator, this person will or will not be able to adhere. right? That one is dicey because it can be very objective and it brings a lot of our biases into the room. Many times we say, oh, adolescents won't adhere, this people won't adhere. We kind of use that for wherever we think. And so what does that mean? And being specific about that, which I can't speak to your profile of resistance. I think there is an important need to, go do the entire dive, right? What were the red? What was this, to really look, to then say, okay, well, what's available or not? And it may be that you have, some NNRTI resistance to one part, may make Cabenuva not necessary or not able to work. But we have lenacapavir, we have other agents coming. So I would keep, every time something new comes up, can we revisit that again? Because this young lady, honestly, I highlight her because it was when I asked her after the fact, 3 months in, 4 months in, how did it feel to be, on this doing well? Her cheeks had filled out. She was now planning for her sister's wedding. And she said, I was trying my best and it was demoralizing to walk in every time and people tell me I was a failure. She's doing the best she could do, right? And so at the hospital visit, when she was in and hospitalized, it was like, well, go out and do it again. And we had to literally fight administration to do something different, right? To literally save her life. So I think it's just push, 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 and elevate these voices and saying we need to be included, and then trying something else.
I wanted to circle back on Porchia's comment about, we call it the cliff, the pediatric to adult cliff. And it's fair to say that probably happens with research as well. It's like, it's not a period of my life I would like to revisit again. Not only did I have to switch from pediatric to adult care, but I also had to make the switch from military to civilian care. So, at age 40, I just hit 40 years with HIV in August. Like I have no idea how I made it through that time. But certainly participating in elective research, and at that point, purely just for other people's benefit of research is not a priority. But I will say that starting in research at that age for me, and more specifically, I think the NIH Clinical Centers is a special place because, it's intramural, it's free. You do have to travel there if you don't live near Bethesda. But for me, what made my participation, I guess, motivated to keep returning is that I did learn about what were the outputs of my inputs. And I was able to see myself go from the youngest patient in table 1 at 19 to I couldn't figure out which is the ideal. I'm not supposed to be able to tell which patient I am in table 1, but because I was the youngest one in the adult clinic, I was able to do that. But I know what I get out of my participation. And most recently, I did second author my living donation with the kidney in the Lancet Regional Health Americas. It's in the August 2023 issue. And my 2 successors also co-authored as well. So I think patient partnership in research is going to be an emerging thing. I don't want to hear that it can't be done because I literally just did it. You can go read about it in the Lancet group. But yeah, I think at this point of the epidemic, researchers need us. And what is it that they're doing to give up their comfort and give up their power to reach us? Because we're not hard to reach. They find us hard to connect with.
So before we say anything else, Porchia, Shanika just sent a message in the chat that talks about the GeneSure archive test that she used to be able to find out if she was a candidate for. I'll send this to you, okay? I'll send this name to you so you can ask and hopefully get that big problem solved. So, ladies, what about cure research specifically? Is there anything that you think is interesting about it? Would you like to do it? Would you not like to do it? And maybe tell us why. And please be truthful. But I don't think we're going to have any trouble with this gang. Tell me what you think. I love it.
What was interesting, Linda, we had a discussion at the USCHA. We had a strategy session, a Lifetime Survivors strategy session. And we had a discussion on if we would, the group we were all talking about, would we take the cure or not? And it was interesting because I most definitely will. I think I would definitely be in line for the cure, but I would want to wait a little bit just to see, I wouldn't want to get it first. I would want to wait maybe to be maybe like the 20th or 30th person to see how it's going to affect others first. I mean, that's just, I feel like something that we all can relate to, of just wanting to see how these medications are going to, or cures or whatever, is going to affect others. But we were, interesting enough, a lot of folks were talking about how like the social aspect of the cure, like of what it would mean to, we don't know a life without HIV. So it would be like, you know how folks who've acquired it later in their life, they have that pre and post diagnosis type conflict that they deal with. Well, that will be our post diagnosis conflict of like, dang, now we have, I know we always say we are more than our status and our, but again, I don't know a life without HIV. So then I would have to get adjusted to, okay, who all of my work that I've done has been in this field. You know, I feel like that's why God has, what created me is to change, you know, that perspective of what it means to live with HIV. That's been my purpose. So then like my purpose will be gone after that. My work will be done after that, or will it? And then like, you know, just, you know, again, the damage is already done in my body. Like, yeah, we will have the cure, but what about like, again, the inflammation, my kidney issues, my HIV brain that I was telling you guys about, like how will that change things? So those were my thoughts. And I know Grissel and Nina might have want to add to that and share their thoughts of what we were talking about in our strategy session too.
Yeah, no, definitely. I think it was a mixed bag. And you know, from my perspective, I've always said, you know, like, yeah, like I wouldn't be first in line, not just out of distrust, but also just, you know, speaking from a place of privilege in terms of I'm doing all right, you know, and there are certainly people who might benefit from early access to the cure, right? And so, you know, I think that there's that. I think, you know, I think a lot of us would be interested just out of like medication fatigue. If you can tell us that we don't have to take medication ever again, you know, like sure, sign us up, right? But there's also, yeah, just like acknowledging that HIV is ultimately a symptom of larger systemic issues. And, you know, like not taking the focus away from that, you know, like not taking the focus away from all of the other, right, like medical issues that have come up, right, that Dr. Agwu, you know, provided a summary of, like you're experiencing all of this. And so, you know, how do we balance focus between, yes, we should be working towards a cure, and also, yes, make our lives right now comfortable, because we've never held our breath on it. Right after 40 years, we haven't held our breath on it, and you know, we're not going to start holding our breath now. And so it is important that our current quality of life is, you know, improved, both from like a physical and medical standpoint, as well as from a socioeconomic standpoint.
Nina, did you want to say something about it?
I mean, the reason I participated in the RID HIV study here in Atlanta was mostly because I didn't have an HIV cure study in my little volunteer portfolio, and it was something I wanted to do before I turned 40. I certainly know that me providing data, for me, it was about representation. There aren't a lot of Hispanics who participate in clinical research, and I wanted to represent a younger demographic. So I did that in my 20s and my 30s. And then essentially, you know, I kept hearing all this HIV and aging discourse that didn't include me. So I was kind of like, well, if I've aged with HIV longer than most people who are age 50 and over, and there's no place for me, I mean, I kind of got dissuaded and was like, well, I've certainly given enough. Maybe I'll take a 10-year sabbatical from research and come back when I'm 50 and technically aging with HIV at 50. So in terms of having an HIV cure for myself, I mean, I'm happy to contribute data that will help lead to a cure. Do I need it? Do I feel a lack in my life? like the stigma is not going to go away just because we have a cure. And we've heard some of that from folks who have been cured. Adam Castillejo, aka the London patient, has said that, you know, he's had feelings of ostracization from the HIV community just because he's cured. And he does share, you know, with folks that like just because you're in remission from cancer doesn't mean like your cancer experience goes away. So I think what is it that we're putting all of our eggs in the cure basket that we think cure will make go away? I don't think until we get rid of this extreme long-held distrust that some body with a virus is inherently bad and a body with the virus is inherently good, I'm not sure what all of these new biomedical interventions are going to accomplish because the systemic problems will still be there. So in essence, we're throwing life rafts for people, but the bridge is broken.
Mm-hmm.
Wow, what a mouthful, ladies.
I just wanted to point out the poll. I launched the poll since we're 2/3 through. I wanted everyone to see it while it's there. You can just tell us. We're just doing a quick little like how you are satisfied with this. And I would like to point out a question that came up in the chat earlier on that Jeff Berry asked. He was asking about research into the inflammation that lifetime survivors might have versus long-term survivors. Has anyone done any sort of qualitative or quantitative research that compares the effects of having lived with ART from a child and going through childhood and all the development of the body? Has there been any work that way with lifetime survivors looking at that and how they might differ from their elders?
I mean, if you're talking about reservoirs specifically, you know, how you get that data is very invasive and very intensive, which I know from personal experience. So I honestly don't think we have enough data without having had other participants submit to things like leukapheresis and fecal samples and lymph node biopsies.
I think when Debbie Prasad has looked in the FACS cohort and compared lifetime survivors, now these are younger who have been on lifetime ART with good suppression and their levels of inflammation compared to those who started later. We know starting earlier, your levels of inflammation are going to be lower, right? And your reservoir size and inflammation lower. So we know that in terms of correlating, like Lena's alluding to, we're saying 10 years of lifetime HIV versus acquiring HIV at 20 versus, I don't know that those have been done as delineated as intentionally as possible. I think that's really what we're getting at is 10 years equal 10 years if those 10 years are when all the things were forming, right? Versus 10 years after you're really formed. I think that's the question. And to get to, do we know that cure is going to erase that? I don't know if it's like smoking. We know if we stop smoking today, we reverse some things. I don't know that we know that we'll backtrack. I think we'll prevent future. I don't know that we'll clean it up, what's happened already. I think it's a great question.
Yeah. I think we all were curious about it. So thank you for saying it more succinctly than I asked, but I appreciate that.
Jeff Taylor, did you have any more questions?
Well, Dr. Agwu brought something up in the chat that's really important. You know, we talk about how difficult it is to do this research here in the US because there are so few, but worldwide, there are millions and millions of people who are lifetime survivors. And sadly, you know, it's still happening right here. We've managed to mostly stop perinatal acquisition of HIV. So, you know, we talk about the research. There's lots of people to research. There's lots of research questions. It just needs to be global. It's probably not realistic to do it here. So I'm interested, Dr. Agwu, on kind of your perspective on how we could do that, leveraging existing, you know, cohorts and research. There's lots happening. How do we answer these questions as well?
So I think, you know, I think about this a lot because I put up the world map to try to make sure we orient ourselves to say we're here where we think we have 12,000 or so. When we look at the proportions of the population living 15 to 49, and we know that the rates of perinatal transmission that were occurring, that significant numbers of people worldwide are living. To get to your question, Jeff, in terms of how do we make sure we capture them, you know, I think we're a little bit behind, right? Because there are cohorts like IDEA and some that are trying to pull together these individuals and trying to catch them earlier and then hopefully longer. So that's for just even cataloging, where I think they're going to see what we're seeing here. We have higher comorbidities. We see that. How do we get to getting people in studies? I'll speak specifically about cure studies. A lot of this has been targeted at the youngest of the youngest, trying to get, early initiation of ART and hopefully driving babies and infants and toddlers into remission. This age range here, and the older, I think it's more just chronicling. It's not in the space where we're putting in cure strategies or what have you. It should. And I think where we need to move, I'm going to do a little advocacy. We have to think more about how not just the things we do here then trickle down, but how do we include the whole world in all of these things that we're moving forward, right? So it's a good question. And I think one that, Linda, when you talk to Carl, you can ask him about how we can do that more.
That's interesting, right?
Yeah, thank you.
Alistair.
Dubé is doing a lot of good work with the fresh cohort in South Africa, but again, that's young women who've acquired HIV as young adults, not that population. But so there is work happening. We just need to leverage it to include everybody.
I think there was a question in the chat about like how old we were when we were each diagnosed.
Oh, yes.
Or how old were we when we were diagnosed? And I'll just say I acquired HIV at 6 weeks. I did not find out my HIV diagnosis until I was 8.
Wow.
And I didn't meet anybody living with HIV until I was 17.
Wow.
And in the context of meeting that person, I think it was a group presentation for the National Youth Leadership Forum on Medicine. So a bunch of young kids who wanted to be pre-meds and things like that. And right before the guest, who was a white cisgender gay man, came in, somebody had said, blood transfusion cases are so rare, they just don't happen anymore. And I think that's pretty emblematic of what people think when they hear that there are still people living with HIV who had it their whole lives.
I was in the 6th grade. I'm not sure how old that is, like 12 or 13 in the 6th grade, when the social worker at Children's Hospital LA came. Like, I think they set that up, my parents and my providers, for the social worker to come and take me to a whole different room. And they kind of asked me all these questions about, like, was I being sexually active? Was I interested in being sexually active or in the opposite sex or whatever? I wasn't even thinking about that really at that time. And then they gave me...
It was your fault, in other words, was what they were telling you right off the bat.
No. I don't think that's what they were saying. I think they were just trying to gauge and see if I was like being sexually active. And then they gave me a HIV 101 and like told me I had HIV. But this was like back in the 90s. I don't know how old I was when I was in the 6th grade. And so it was really sex negative, the HIV 101 that they gave me. And then I was like, I had heard the word HIV. No one ever sat with me and told me what it was. And like,
that's very real.
Terrified after that, like, oh my God, I can't have sex. I can't do this. I can't do that.
It's counseling people with HIV through their sexual debut. I think that's everything. It's a pretty universal experience of all of us who acquired HIV early on in life.
I'm in middle school and I'm just like, oh no, I can't kiss. I can't, it was not a great experience.
Wow.
Yeah. And for me, I was, I acquired it through breastfeeding, and wasn't diagnosed until I was 5 years old and had migrated from Mexico to the United States. And I was very fortunate in that my mom told me when she found out, I found out. So I've known about my status since I was 5 years old, which to me, I consider a gift and a privilege, because I was able to accept my HIV before I knew what stigma was. And so, I had the benefit of like, there's anybody could tell me about me, right, that is going to make me feel bad about. So that to me was a gift from my mom in her approach. But I also want to come back to a comment that Nina made about, like people like just assuming that what transfusions weren't happening anymore, but also even to this day, just the assumption that perinatal transmissions are completely eliminated, right? Because I right now we're focusing on the oldest of us, right? But I also, don't want to forget that there are still children in the United States who have acquired HIV perinatally. And, I also don't want them to feel so separated and so forgotten, right? Kind of like from those of us who are older, right? Because, there's going to be that gap of like, yes, there's, several thousand of us, right, who are probably in this kind of, 30s, entering 40s age group. But then I think that group of younger children is going to be smaller. So they'll continue to have that experience. So, yeah, and I'll pass it on to Dr. Agwu.
Can we do a PSA on screening and pregnancy, Dr. Agwu? It's not just HIV, right?
Oh my gosh. No, thank you for that segue. You saw my hand pop up. And I think we had 6 babies and 6 children, mostly babies, diagnosed in Maryland last year, right? And I think when we did a panel somewhat like this with the team and with the woman whose 6-year-old had been diagnosed, I think it was 6, she said, I did my early testing in pregnancy, and then that was it, because nobody talked to me about not having, how I could acquire HIV during pregnancy, because pregnant women don't have sex, right? And so absolutely, 1st and 3rd generation testing, trimester testing, and then actually engaging people in how they can protect themselves, prep in pregnancy, and then testing at birth for infants. So absolutely, and not a reason not to breastfeed, because we now know breast and chest feeding is something that we support. I think all the pieces. Thanks for the plug. We are absolutely seeing congenital syphilis. We're seeing record cases of syphilis, and oftentimes syphilis and HIV go together. So absolutely. And in terms of the ones that are still acquiring HIV, these kids, you're absolutely right, Grissel. I think one of the things I oftentimes do when disclosure happens, and I love your disclosure story around 5. Unfortunately, I've seen disclosure story happen at 12 or 15, and most recently 19, because we say, there's nothing wrong. We just didn't tell you. Well, absolutely, there's something wrong if you waited till I was 18 or 19. And so you've compounded the stigma by doing that. But I oftentimes talk to the young kids when we disclose about the long-term lifetime survivors and say, I have people who are 40, so you don't get to use your HIV as a reason. You don't get to do your homework or go to school. It's actually motivating. So I think figuring out ways to connect them early, absolutely empowering and supportive. And I think we should make that happen in some way so they can see you all.
Should have used that excuse when I was younger.
Exactly. Oh, my HIV is hurting. Like, no, you don't get to do that.
Really Alistair, you've been so patient with your hand up. I want to give you a chance to ask a question.
Thank you. Thank you especially to Dr. Agwu and the panel members. Several questions actually raised their little heads during the conversation. One of the things I did put in the chat, which is that just hearing about the potential for there being this large a population of lifetime survivors strongly suggests that we could help both long-term survivors and lifetime survivors by bridging that generation gap, because the long-term survivors have so much experience, lived experience with coping with a complete upturning of their lives, where the lifetime survivors started off in a very different place because they didn't have an expectation that life was going to be normal. But they still learn to cope. So they learn to cope in different ways, but as ancient ones can learn from the younguns that actually found their own coping mechanisms, because that sharing is likely to be beneficial to both sides. The other thing that really stuck out in my mind as I was listening and reading was that is there a particular reason that males are excluded from the panel? Did we intentionally exclude males?
No, not at all. I don't think that was intentional. You know what? We probably should have had a male on this panel, huh?
We
I'm
invited one,
just
but
trying-
they must
sorry,
have had a
but-
conflict. We
Yeah.
invited one, but they probably had a conflict.
No,
But
I'm just trying to point out that the inclusion-exclusion criteria exists for a reason. And we throw that away at literally our peril. Because if we emasculate, neuter, call it what you will, clinical trials by requiring that every single clinical trial must have a representative from every single group, then we're not going to have trials. I grew up in Scotland with people already joking about the fact that we encouraged primate research in Scotland. Because if archbishops were going to be clinical trial participants, that was a great thing. Because the archbishop of a country is the primate of that country religiously. So we're all for primate clinical trials so that everyone is taking part. And if someone rich and prosperous is the first one cured, more power to them, because that gets a cure found. And if we keep insisting that every single subgroup has to be included, we risk not doing the researches that we need to do.
I don't agree with that, Alistair. You know, you just can't
don't either.
leave big chunks of people out. It's just
No,
not
the whole
fair.
point is I don't believe that we have been intentionally excluding people in a
No, I don't
malicious
think that-
way.
I really
think
don't
it's
agree
been
with that.
happening because of the requirements of phase 1 trials.
Well,
We
we're
We've
not
known for a
that
long
we need-
time that
Go ahead,
research is
Nina.
largely white cisgendered men. I don't think
Yeah.
men have a representation problem in clinical research, and
No,
it
we
certainly
don't.
wasn't an issue in the
And
inclusion
that's
of
always
this
been
panel.
the way for every disease, every trial since this stuff began, because it's easier to deal with people that don't have babies, that don't have to take care of babies. I mean, it's, drug companies pick people that are going to be the easiest to study from their perspective. And I mean, we've been stuck with that paradigm for a very long time. So.
As someone who is a parent, I was very careful that none of the clinical trials I took part in could have any effect on my children or potential children.
Dr.
But that's because I was informed.
I'd let her respond.
And that's because I kept informed.
Okay. All right. So, Jeff, did you want to
But
say
thank you for the
something
time
else?
and an excellent presentation.
Thank you.
Yeah, I just said trying to acknowledge that Dr. Agwu had her hand up. And
Okay. I'm sorry,
speak to
Alison.
this.
Go for it.
No worries. I think, definitely perennial lifetime survivor male. I have a great one if you want to do it. I think I had a quote up in his voice, but he's amazing. I think in terms of the inclusion exclusion criteria, I heard what you said, Alistair, and I think, certainly we want to be intentional. If you're doing a trial of pregnant women or whatever, of course, it's not open to everyone. But I think, unfortunately, a lot of times we are artificially excluding, right? Why are we going down to 18? Why can't we go down to 16? Why? So pushing, and if we ask the question, then we do it. Why are we excluding pregnant? Why are we doing that? I think we have to examine why we are saying certain things and doing that and not just repeating them. So if it's not relevant, fine. But if it could be relevant, let's try to enrich those individuals and invite them to participate and make sure we make space for them to do that.
Alison, we had a really big meeting with the FDA last week, and a colleague of ours on the call from New York said that they went, it used to be a research organization that he was involved in, the CRO in New York City. Anyway, they went through years and years of protocols, and it was essentially a problem of cutting and pasting what had been there before, without absolute scientific necessity to exclude people and that sort of thing. So it was a real eye opener, I think, to us and to the FDA about, wow, well, because how many times have you looked at a protocol and you just glaze over that sort of stuff? And you don't realize until you have a call like this, what that means to different groups of people. So.
I just wanted to speak to the intergenerational piece that I don't know how to say his name, the gentleman.
Alistair.
It's Alistair.
Alistair, that he was speaking of. I'm actually one of the chairs of the Lifetime Survivors Special Interest Group for the NAN, which is the National HIV and Aging Advocacy Network within NMAC. And that's kind of what we do. We have men in our group. We are organizing amongst ourselves within our cohort within NMAC, as well as we have our own Dandelions movement, for us, by us movement, that we are organizing for as well. Or, you know, so it's a big group of us, you guys, and there's men. We have all different kind of representation within our group, you know, trans men, non-binary folks, and we have that within the cohort, within the National HIV and Aging Advocacy Network. There have been a lot of those intergenerational conversations that have taken place. They pretty much, the 50 plus network within NMAC pretty much included us within their program, and then within the network. And, you know, at the biomedical conference, at the International AIDS conference, we've been having these conversations and learning a lot from each other. Even some of the work that the Reunion Project has done, you know, we're being included at the table in this HIV and aging conversation, and I really appreciate it. And that's all I just wanted to plug that in there.
I mean, I think, yes, yeah, all of that. And, you know, I think not just that we're being included, but it's also, you know, acknowledging that it's because we're demanding to be included, right? I think all of it really started because, like, Porchia advocated to you know, like, remind people that we are also long-term survivors and that we should be included. I wanted to go back to the question around, like, men, and I had a question, Dr. Agwu. I don't know if you kind of, like, if you can talk a little bit about the rates in perinatal HIV among men versus women. I imagine we don't have data around other kind, like, non-binary folks, which, you know, we should, because we are a very diverse community. Because definitely in advocacy spaces and in social support kind of spaces that we have created for ourselves, like, we do see, like, predominantly cis women. And, you know, like, I think it can also be a very isolating experience for some of people who are not cis women, because there's even a smaller group. And so, you know, I think, like, they're a really great part of our group, and, you know, that we so far haven't had any issues in them feeling like, okay, the women are the louder voices. But just from a, like, you know, epi perspective, wanted to know if you have any information about kind of, like, whether there truly are more cis women.
So I don't think by numbers wise there are. I think I mentioned on the graphic about, and there's not good data for the older. I have to be careful how to use older, because above 25, right? So we know in the 13 to 24, about 10% of individuals who are classified as male, 10% are perinatally or acquired infection that way, and then about 40% of women, again, because of the way the larger numbers of individuals acquiring through same gender loving behavior for males. I definitely can't speak to older, because I think it's some of the unknowns and things not clarified. I do think it's important to elevate the voice. I think I want to point to Larry's comment in the chat about heterosexual males, right? Oftentimes they're not part of the conversation either. And way back data we looked at through HIV Research Network, we realized that those males were more likely to be later diagnosed and come presented to care more advanced, in, you know, lower CD4s, because people aren't thinking about them, or they're not engaging in care. And so we need to make sure that we elevate their voices as well. So thank you for bringing that point, Larry. But those are the numbers that I can think about, Grissel.
Denise, I see you raised your hand. Did you want to ask your question?
More of a comment. Thank you, panel. This is really excellent. I got very interested in the Dandelions at the conference when they came up on the stage and they expressed that they will not be in the foreground anymore, that they're going to be up front. I was like, all for it. I came down. I wanted to get into the session, but, you know, with Grace, they said it's a closed session for now. And I'm very interested in it. What I also noticed, in the beginning, there was a lot of celebrity around children that were born positive. And then it was almost like a fad. When that celebrity wore off, those children got lost in the source. And I've run into them, and they're not doing very well. So I'm glad that you have formed this dandelion community, and that you are being more supportive of one another, and that you're bringing people into the fold, because it's not a fad. It's people's lives. And I hope that safety net reaches out to all of those that in the beginning was like the face of it, and they got a lot of, and then they kind of like fell by the wayside and are struggling a little bit. So thank you for that.
Thank you. And, and I think this also brings up, like the importance of when we talk about research, not just thinking about clinical medical research, but also thinking about behavioral research. Because, right, kind of like if in terms of the epi, like there are more equitable numbers among men and women, then I think we're not seeing them, more so probably for behavioral reasons, in terms of, right, kind of like internalized stigma, particularly if right, from like heterosexual cis men, right, kind of the stigma that surrounds that kind of experience. And so I think we can't forget to include behavioral research in terms of our priorities as well.
Mm-hmm. Yeah, I agree more. There's from just like talking to folks within our population, and even outside of our lifetime survivor population, straight men, I think behaviorally, like, they don't want to be public or out in the open as much as like, or speak out about these types of things as much as we do. I'm not sure why, or I do know why, because of the behavioral reasons that Grissel just highlighted.
I wanted to make a distinction that the struggle that I saw was coming from a young woman. So, if we can, just make sure that we check on one another and make sure that everyone doesn't fall through the cracks, because this was a young woman that was obviously struggling.
I know who you're talking about, Ms. Straighten. We invited her last year. She's a part of, I check out her I check in on her from time to time. Yeah, I know exactly what you're talking about.
Allisonn, I think you have to leave. Thank you so much. Great presentation.
Thank
great
you.
interaction.
Thanks for sharing. Thanks for inviting me. Love to come back and connect.
Okay, great. Have a safe flight.
Will do.
Yeah, I just wanted to say that I feel like this is how I knew I was different from most people. That growing up, that a lot of lifetime survivors had this focus on being desirable, whether that's like sexually or romantically. And like I was saying in the chat, a lot of the lifetime survivors I know that are heterosexual men were like just focused on getting married. And certainly with kids with hemophilia, there was a strong advocacy community that was mostly men in that group, because that's like who's disproportionately affected by hemophilia, that once they got to an age where if they were lucky to live long enough and get married, like they just wanted a life outside of HIV. So irrespective of whether or not, there are people who fit certain demographics, I think when you're looking at this group in particular, you have to recognize the emotional research, long time labor that they have put in, and respect that, unlike a lot of other people who got to experience a childhood free of stigma, like these people who have survived a lifetime of HIV want to live for themselves.
Well, I mean, it's almost time to close, but I'm like flabbergasted. This has been such a wonderful session. I mean, I think we got our highest ratings. I've been looking at the chat as it comes up. Everybody's been delighted with the conversation, with our attendees, your advocacy, and you're just like, wow, perseverance and fortitude. So we will be checking in with you again, ladies. We're not going to leave you behind, I think. I think we're going to be pretty sure about.
We know how to find you.
Yeah, no, that's good. That's good, because you know what? It's on you to do that too. So, we know that you're connected there, and we know we will hear from you. And we just want to tell you that we welcome hearing from you. So I think this was a great session, and that you all did a fabulous job. So let's give our ladies a hand. They were fabulous.
You can also give
Anything you all want to say
Awesome.
before we leave?
Who were you asking that of?
Anybody,
Oh,
panelists.
I just want to verbally say that I will be putting the chat in an email with links to the recordings once I get them made, which will be later today. And I'll be sending those emails out to 751 of you who've given me your emails. So you will be getting this sometime this week. I am trying not to have the UW system crash, so I send out in groups of like 30 emails at a time. You will all get it this week sometime. Just give me a little patience. I appreciate that, but it'll be getting out to you there. Okay? Thank you so much.
And our next webinar is on October 24th, and that's going to be, the title of that is Participant Experiences in HIV Research. And we're going to have Paul Edmonds will be joining us. He's the City of Hope patient that was cured. Matt Sharp, Tom Villa, Gail Graham. So that should be interesting as well. So hopefully you will join us. We thank the panelists again, Dr. Agwu, who was gone for her trip, and for all of you who attended. So it wouldn't be the same without somebody listening to us, would it? Thank you all.
Thank you all. Take care. Be well.
Right.
Everyone.